Okay. So we're doing maternal newborn exam 3. And we're going to start at the very beginning of this with chorioamnionitis. So the other thing that I want to go back real quick to is well, if I can find it. Here we go. I want to go back to this guy and look at what chapters we're working on. So the stuff from exam 3 is week 7 and 8 primarily, but we still are looking at the postpartum complications we did in week 4. And so that comes from chapter 21. So we're doing chapter 21, 22, 23, 24, and 25. And so when we start with the beginning of this PowerPoint, we're thinking about infections. And so that is taking us back. And it actually takes us back a little bit further than chapter 21, because when does chorioamnionitis happen? Does it happen in pregnancy or in postpartum?
It happens during labor.
Right. And so she's still pregnant. So we're actually going back even further. But this is one of our big causes of our infection later. So let's just remember chorioamnionitis. What do we remember about chorioamnionitis? What is infected?
The amniotic fluid.
The infection's in the amniotic fluid. It's in the amnion and the chorion, those membranes that surround everything. And so what signs and symptoms might we see for this?
Dark amniotic fluid.
Okay, we could have like purulent amniotic fluid. What else?
Fetal tachycardia.
Good, fetal tachycardia. What else?
Uterine tenderness.
Uterine
and fever.
tenderness. Yeah.
And fever in the mother.
Yep. Good. Mom will also probably be tachycardic. Okay, so we will see maternal and fetal tachycardia, fever, uterine tenderness, and then that foul smelling purulent amniotic fluid. How do we treat it?
Antibiotics.
Antibiotics. Good. All right, so then we move into our postpartum infections.
Well, we need to know the specific antibiotics that they use.
It's usually a broad spectrum antibiotic. And what I see typically for this is typically I actually see them use a combination of 2 antibiotics. I don't think that it goes into this much detail in your book. But I see a penicillin, like penicillin, ampicillin, something-cillin, and gentamicin.
Okay.
And in that way it covers both the gram-negative and the gram-positive bacteria. Okay, but I think as long as you recognize like normal antibiotics, you can be like, oh, that's an antibiotic. That might be what we use. Okay. So for our postpartum infections, what do you guys think are the infections that we worry about in the postpartum period?
Endometritis.
Endometritis. And if mom had chorioamnionitis, that might infect her risk of endometritis, right? What signs and symptoms do I see of endometritis? You remember what our signs and symptoms were here? Guess what? Similar. Uterine tenderness, foul smelling discharge, fever. Okay, the baby's not tachycardic in this one because now the baby's out, but mom can still be tachycardic too. All right. What's infected with endometritis?
So with like the stuff that's grown outside the uterus?
Not quite, but I see where you're going with that.
Isn't it the lining of the uterus?
Yeah. Okay. So think about if we think all the way back to like week 2 or even week 1 when we looked at the structure. The uterus has a myometrium, which is the muscle fibers, and it has an endometrium, which is the inner lining. And with endometritis, that's what's infected. Katie, I think you're thinking about endometriosis and how that grows out. And that actually is a proliferation of that endometrium as well. Okay, but with this, the endometrium is infected. So we have foul smelling discharge, maternal tachycardia, fever, and uterine tenderness again. And so because that there's certain conditions or certain times that we would be increasing our risk of infection, we might give antibiotics as a prophylactic. Do you guys know what a prophylactic is?
Before anything like shows up or they start reacting. So it's kind of like a precautionary.
Exactly. Good. Say I couldn't have explained that any better. So when might I give a prophylactic antibiotic to try to minimize the risk of developing endometritis? Do you think?
With cesarean.
With a C-section. Because if we open the uterus, we are increasing our risk of causing infection inside the uterus and the endometrium. Okay. Other postpartum infections besides endometritis is our most common one, but what are some others that we are watching for, assessing for?
UTIs.
UTIs, yep, absolutely. What are some things that we can teach mom to do to help minimize her UTI risk?
Fluid increase and voiding as much as possible.
Good,
Right.
keep emptying the bladder. Also good pericare. All right, keeping that area clean, using her peri bottle, changing her pad frequently, keeping the area clean, but definitely that increase in fluid to help keep that bladder flushed out is a good idea. All right, what about mastitis? What's infected?
The mammary glands?
Okay. With the mastitis, we have an infection in the breast. Right. And so we're concerned about our symptoms are similar. Again, fever, tachycardia. In this case, now the tenderness is going to be in the breast. What's it, tender, whatever is infected is where the tenderness is. And so the breast can be tender. We can have a really systemic response to mastitis where they develop like flu-like symptoms, achy and feeling sick. And how will we treat?
Antibiotics, frequent pumping, warm compresses, hand expression.
Perfect. Exactly. Okay, we want to keep emptying that breast. The warmth is going to help the milk let down. Hand expression and pumping is good because that if they latch the baby, which they can do, and they can breastfeed with mastitis, but it is so uncomfortable. So oftentimes they opt not to. Okay. All right. So postpartum hemorrhage. So now we're still thinking about that chapter 21 stuff. Okay. And so you have to still kind of dig into your week 4 brain. All right. So with postpartum hemorrhage, we have early hemorrhage and late hemorrhage. Do you know the difference between these two?
Late hemorrhage happens after the first 24 hours.
Absolutely. Okay. What signs might I see of a late hemorrhage?
The uterus not returning back to normal, the pre-pregnancy state.
Good. What's
would
the
have-
term for that?
Subinvolution.
Subinvolution. Perfect. Okay. So so keep going with your thoughts. So if we have failure to return the pre-pregnancy state, what are we seeing with this?
Prolonged lochia and bleeding.
Okay.
An enlarged uterus, a boggy uterus.
Enlarged and boggy. So what is boggy?
It's where it's soft. It's not firm.
It's not firm and it's enlarged. So think about how the uterus is supposed to return to its pre-pregnant state. How far much does it go down per day, do you think?
Is it 1 centimeter, like 1 finger breadth? Is that what
Exactly.
it's called?
Yeah, that's exactly right. So it should be going down about 1 centimeter or 1 finger breadth per day. And so if we have an enlarged uterus, then I am palpating it at a higher place than I would anticipate based on how far she is from delivery. Okay. And then if this is happening, if we have a boggy uterus and we have subinvolution, then we probably have some bleeding issues. So when we're talking about prolonged lochia, remember lochia follows a kind of a process where we're rubra, serosa, alba, and it's not supposed to go backwards. And with subinvolution, oftentimes either it stays rubra or it goes serosa, then it goes back to rubra. What would cause this, do you think?
Maybe a laceration.
Okay, so our lacerations definitely is our number 2 cause of early hemorrhage. But for our late hemorrhage, where our uterus is not involuting the way it's supposed to be, we need to think about things that could be inside the uterus that is keeping it from contracting down and returning to its pre-pregnant state.
So like pieces left over from placenta, infection.
Yeah, and those are the 2 main things: retained placental fragments and infection. And what's the name of that infection?
Endometritis.
Endometritis. Okay. So endometritis and retained placental fragments are big culprits for subinvolution. And that's where we get the boggy uterus and the irregular bleeding and all that. Early hemorrhage. So early hemorrhage happens in the first 24 hours. What's the number 1 cause of an early hemorrhage?
Uterine atony.
Uterine atony. Okay, if the uterus is not contracting down, it's not squeezing and tamponading those vessels that were feeding the placenta, and it can bleed a bunch. Okay, so if we have a bleeding and we have a boggy uterus in the first 24 hours, I'm thinking uterine atony. How would I know? Like if I see bleeding, what's the first thing I should do?
I'm gonna check the fundus.
Massage a fundus, and then I'm going to know, is it firm or is it boggy? If the fundus was firm and I still saw like a trickle of bleeding, then what do I think might be causing the bleeding?
Some type of laceration.
Yeah.
Or maybe a hematoma, if you can visually kind of see how swollen it is, like in the picture on the PowerPoint.
Okay, so yeah, the hematoma, that's like a huge hematoma, so that you guys understand what they look like. If I see that, that's concerning, right? With a hematoma, I'm not seeing bleeding because the blood is collecting in that tissue. If that hematoma was tucked up and not kind of on the labia that way, if it was in the vagina and not as easy for me to see, when we're thinking about recognizing and analyzing cues, what might I assess or see in my patient that would be a red flag to me that maybe the patient had a hematoma?
She'd feel maybe a bunch of pressure.
Pain.
Pressure and pain, absolutely. What else do you think?
High blood pressure.
Crackers, you want some?
Do you think the blood pressure would be high?
I think so.
Why do you think that?
That's turkey salad.
Why
Would
do you think
the
it would be
heart
high?
rate be high and blood pressure low?
Yeah, we would see the fluctuations in our vital signs that we see with hemorrhage. And the very first thing we usually see, the very first vital sign change we usually see with hypovolemia is tachycardia. So the heart rate could be high, but blood pressure could be going down depending on how much blood is collecting in that tissue. And that's your hematoma. Okay. But most of the time, uterine atony is our number 1. And so how do I treat it? So if you go in and you're assessing your patient and her fundus is boggy and she has a puddle of blood and clots this big between her legs. What should we do?
I'm gonna massage and call for help.
Massage, what, and yep, let's call for help. What else? So help comes, what else should happen? What are your friends going to do to help you?
I'm gonna make sure she's urinating, probably hopefully have a cath placed in.
Good, manage her
Uh,
bladder.
Make sure we got 2 lines open for fluids. Make sure they're going really well, and that Pitocin is going like it should,
Okay, why do you want to give Pitocin?
to help with the contractions of that uterus, to help give it an extra bump on top of us massaging it.
Mm-hmm.
Sorry if it's loud in the background.
I don't hear a lot in the background. Okay, so we've got a friend that is massaging. Okay, you're massaging the fundus, and your friends came and somebody put in an IV, a second IV. Is that what you said? Or am I making
Yeah.
that up? I was
No,
gonna
no,
say,
yeah,
if not, she needs one. Somebody
was kinda
puts
like
in a
just saying a
second
lot.
IV. Yep, good. Somebody puts in a second IV. Why do we need a second IV?
For blood products.
Okay, so that I can really quickly give her volume. What's the concern? Okay, so she's got, let's say so I said she had like, this much blood between her legs. And so one of the friends that came in weighed that. And remember, 1 gram of weight is 1 milliliter of blood loss. And that pad weighed 850 grams. Okay. And so we got a second IV in because if she is losing that much volume, what am I concerned about for her?
Going into shock.
Good. And if she goes into hypovolemic shock, what kind of signs and symptoms might I see?
She just starts to bottom out.
What's that?
I was gonna say lethargy,
Okay.
super low blood pressure,
Yep. Hypotension.
increased heart rate.
Yep. Tachycardia. Cool, clammy skin. Probably decreased urine output because we're not perfusing the kidneys. And so
Or
by
loss
getting,
of conscious.
yeah, I hope not, but absolutely could happen. And so by having 2 IVs, we can give her volume and we can try to maintain oxygenation to those tissues. So you're right that we might be putting blood products through them and through one, and then we can also be doing a lot of IV fluid. All right. So you said second IV, you wanted to manage the bladder. And so we had 850 on that pad. So am I going to get her up to the toilet?
No.
No, probably not. So we'll put in a Foley. And what else did you, you wanted to start Pitocin. And what is the Pitocin going to do?
Help with contractions.
Help the uterus to contract because the uterus is boggy. That's the problem. And so let's see, did I miss anything on what you said to do initially, what your friends were helping with?
No, that's practically everything I was saying.
Okay.
I have a question.
Yep.
So uterine atony is the immediate right afterwards, like within the first 24 hours. It becomes sub-involution after the first 24 hours if it's not contracting back right.
Correct.
And atony is the same, like in that it should be moving it should be moving back down 1 centimeter, and it's not at all.
With
Or it's just
atony, the word atony,
Mhm.
A is like if you say atonic, if you say what's something else that has an A in front of it, A means the absence, like it doesn't have it.
Mhm.
Asymmetric.
Mhm.
Okay. The A on this means absence. It doesn't have it. And then the rest of the word is the word tone.
Okay.
So uterine atony is the absence of tone, which just means the muscle's not contracting. And we
Okay.
had this, there was so much blood flow going from the mom's body through the uterus to the placenta. And these vessels have become very large to just for a large amount of blood exchange for the placenta. So when the placenta comes out, that muscle has to squeeze and tamponade those vessels. And if it doesn't, if we have atony or the absence of tone and we're not squeezing the vessels, these vessels can just bleed like crazy. Okay. Now with subinvolution, we're looking at the uterus contracting and staying contracted and going back down to its pre-pregnancy state. Is involution. With subinvolution, it's not doing that. We can see uterine atony here. We can see a boggy uterus. We can see prolonged lochia where it's staying rubra, but this is probably not hosing blood the way this is. Okay. So we wanted to, does that answer your question, Katie? Okay. So we wanted to give Pitocin to help the uterus to contract. What other medicines could we use to help contract the uterus?
Metrogen.
Metrogen, good. And when would I not want to give a patient Metrogen?
High blood pressure.
Yep, if she's had high blood pressure. Good, because Metrogen causes vasospasms. It can cause, and so it's not a concerning thing for a healthy person, but somebody who's got high blood pressure, it can cause the blood pressures to increase even higher. So we're not going to give it to somebody who has high blood pressure. So who might have high blood pressure?
Patients with
Preeclampsia patients.
Yeah, your preeclampsia patients. Your preeclampsia patients shouldn't have Metrogen. Okay. What other medicines could I give?
Hemobate,
Hemobate. All right. What's the contraindication for Hemobate?
asthma.
Asthma. Because it causes bronchospasms, which is fine for your normal person, your healthy respiratory wise, but for your asthmatic, not so much. Okay. What else could we give?
Cytotec.
Yep. Cytotec. And so Cytotec or misoprostol is that medicine we talked about that in your non-pregnant patient is really a GI medicine used to treat ulcers. And they found that it causes uterine contraction. It is a prostaglandin for the body that if you looked it up in a med book, it would say pregnancy category X, because we in tiny doses, like 25 micrograms or 50 micrograms, we can cause cervical ripening and cause labor. Now in the postpartum period, we'll give a bigger dose, like 800 to 1,000 micrograms, and it's going to cause the uterus to contract. Okay. All right. Good. So we put in a second IV, we managed her bladder, we gave her uterotonics. Utero is uterus, tonics is tone. We're giving medicines to make the uterus contract. And we are really working on preventing the hemorrhage and to the point where hypovolemic, and we're working on keeping oxygen going to the organs. So what's the goal for our patient? Tissue perfusion. Also stopping the bleeding. Okay. Make sense? All right, so then let's do coagulopathy. So the one that we're going to talk about is idiopathic thrombocytopenia purpura, or your book also calls it immune thrombocytopenic purpura. Any idea what this is?
It's an autoimmune disorder.
It is an autoimmune disorder. And what does it affect in the body?
The platelet count.
It affects the platelets. And so with this, the platelet lifespan is shortened. And so it causes thrombocytopenia, or it causes the platelet counts to be low. If she has low platelets, how does that affect labor and delivery?
She could be at higher risk for severe hemorrhage because those platelets are not clotting like they should, or they're so low, not that they're not working. Sorry.
Okay, so yeah, so she's at a high risk of having a hemorrhage. And so with this, we know that she has low platelets. And so we can, before she even goes into labor, or even maybe in labor, medically manage her in such a way to help stabilize the shelf life of her platelets. So how would we do that? Well, how would we treat this?
Corticosteroids.
Corticosteroids. Corticosteroids are going to help expand the life of the platelets. All right, so that hopefully we decrease that bleeding risk. But guys, if my patient, like we had one that was just a scheduled C-section, and on her problem list, ITP. And I was getting a report and they said, so according to her prenatal, she has ITP and blah, 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 blah. I went, okay, do we have a second IV? No. Do I want a second IV for her?
Yes.
Yes.
Yeah. Guys, anytime your patient is at risk of hemorrhaging, let's put a second IV in. All right. It's uncomfortable for the patient, but it's kind of like a seatbelt, right? When you get in your car, you're not planning on wrecking your car, but you cannot put a seatbelt on while you're going through the windshield. And I'm going to have a really hard time getting a second IV in a woman who is hosing blood. Okay. So if she's at risk of bleeding, I want a second IV. And that's true for this patient. Okay. So huge hemorrhage risk, just because of the instability of her platelets. But usually if she's had good prenatal care, she's probably had corticosteroids in pregnancy, and we can also give it to her on admission, or we can even give platelet transfusions and things like that if we need to.
So is this something she would have had like during the entire pregnancy, or is this something that happens right after she gives birth?
This is something that they find in pregnancy.
Okay.
Yeah.
So how long after pregnancy, or is this like a lifelong thing now? She's just going to have low platelets.
I don't know the answer to that. I don't know if this is a gestational thing that'll resolve, or if that's just her normal. So
Okay.
at the very beginning of pregnancy, remember how we talked about what labs do we want to know? What information do we want? And we wanted a CBC, and we wanted to know what her H&H was, and we wanted to know what her platelets were starting out. And this is part of the reason we wanted to see how that is. And then we can check it. They check it again periodically through pregnancy. Sometimes though, I mean, there's other things, like if you think about platelets in relation to preeclampsia, remember that preeclampsia and HELLP syndrome, those platelets get really low. And so those patients also at risk for bleeding. So there's a lot of other conditions that can cause thrombocytopenia, but this one is the autoimmune one. And so we can treat with corticosteroids. Mood disorders. So do you guys know the difference between blues, depression, and psychosis?
Yes.
Okay, so if I was a brand new mom and I said, I am 8 days postpartum and I can't stop, I just cry for the silliest things. You know, the Toyota commercial, it's almost Christmas, it's so sweet, and it made me cry. I'm not sleeping very much, and oh my gosh, this baby just wants to eat all the time. And I just don't know if, I mean, I want to hold her and sit with her all the time, and nothing's getting done around my house. And I think my husband's really frustrated with me. What do you think?
I'd
It's the
say that
blues.
one's blues.
Postpartum blues.
Probably blues. Okay. What about now? I am day 15 and I don't want to get out of bed, and my husband can just give the baby a bottle, because seriously, I cannot put my baby on the breast one more time. Can't do it. And I kind of wonder if I even need to be here anymore. They'd be better off without me.
That one's going to be
Be
depression.
Okay, so with depression, she starts to detach from her baby. She's not interested in taking care of herself or her baby. Her symptoms are more severe, and she might have thoughts of self-harm. Okay. Now, psychosis is like, I keep hearing voices and they tell me that my baby's a demon and he's going to destroy the world, and I have to stop this. I have to stop it. I don't know what to do. I have to protect the people. All right. It is random, bizarre. They can have hallucinations, they can have delusions, and they have huge impulsivity, where those are the ones, like if you hear about women that kill themselves and their families and their babies, it's psychosis. Okay. Makes sense? And
Yes.
and she probably needs to be hospitalized. Your psychosis patient. So here's psychosis on this slide. Rapid onset, bizarre behavior, auditory, paranoia, all of that. Okay, so let's talk about something a little more exciting, and let's have a baby. You guys remember APGAR score? With our APGAR score, what are we assessing?
The appearance, their pulse, their grimace, activities, and respiration. Just the overall health of baby when they first come out in 1 minute, 5 and 10 minutes. I don't know if that's right.
Okay, 1 minute for sure, and at 5 minutes for sure. Now, whether or not we assess beyond that is going to depend on how our baby's doing. What number do I want to see?
7.
7
Or
or
higher.
better?
7 or
Yes. Good, 7 or better. If I have a baby that scores 7 or better, then that baby's doing pretty good. Okay, and so if I have a 1 minute APGAR of a 7, then when will I reassess?
5 minutes.
At the 5 minute mark. And so then we reassess at 5 minutes. And then if that baby's APGAR is still 7 or greater, then that's fine. But if the APGAR is lower, that's when we'll reassess every 5 minutes. So then we would reassess at 10 minutes, 15 minutes, 20 minutes, until we're seeing APGAR scores that are 7 or better. Okay. Where is, we'll look at that in a second. Let's go here first. So baby comes out. What should I do? If I'm the nurse that's there for the baby, what should I do? Baby came out and the provider went bloop and just plopped that baby right there on mom's belly.
You want to dry them vigorously.
Let's dry them and stimulate them. Good. Okay, why do I want to dry the baby?
They don't hold heat very well.
Temperature regulated temperature.
Good. Okay. So if we let them stay wet, they're going to get cold. So we're going to dry them. And the vigorously part, why am I trying to dry them vigorously?
Doesn't it stimulate for their lungs?
Yeah. Yep. Let's get that baby crying. That's the best way for a baby to clear their airway, is to cry. And so if we're drying them and we're stimulating them, then we can get a pretty good idea. We can start checking these little items off of our list and noticing their color and their pulse and their grimace and their activity and respirations. Is my baby moving around? Is my baby floppy? Is my baby blue? Is my baby pink? Does my baby have acrocyanosis? Okay. Sometimes we need to suction them out. Okay, because that's going to help maintain that airway clearance. So if they've got gunk hanging out in the back of their mouth, let's use the bulb syringe. How do I do that?
You want to suction the mouth first, then the nose.
Mouth first, then the nose. Okay, because the babies are obligatory nose breathers. And if I try to put my suction in their nose, they're going to go, and then they're going to, everything that was in the back of their throat, look, now they just inhaled it, right? So suction the mouth first, but how do I use the bulb syringe?
You squeeze bulb first, and then you let it suction its own out, and then you spit out.
Okay, so we'll squeeze it, put it in, not straight back where it's going to trip their gag reflex, but kind of on the side. Release to suction, and then squeeze it out there. Okay, good. All right, so maybe suction. All right, assigning APGARs. And I'm looking for signs of respiratory distress. And I'm looking for signs that I'm looking at, for like hypotonia, decreased muscle activity, decreased respiratory effort. So as I'm doing my APGAR scoring, I'm thinking, is this kiddo okay, or do I need help? When might I want to call for help?
Less than 100 beats per minute.
Okay, less than 100 beats. What else?
If I see signs of respiratory distress, so like the retractions between their ribs, seesaw breathing, nasal flaring,
That's so good. There's one other one I want you to hit.
seesaw breathing, retractions, nasal flaring, grunting.
Yeah, good. All right, if I'm seeing any of these signs that Katie just said for respiratory distress, or if I've got a heart rate at or below 100, I should call and get some friends to help me. And that's, if you look at the APGAR scoring tool for pulse, the baby gets 2 points if the heart rate's greater than 100, and they get 1 point if the heart rate's less than 100, because at least they're trying, but that's not really where we want a baby's heart rate to hang out, right? What's a baby's heart rate supposed to be?
$110 to $160.
Yeah. Okay. All right. So if, let's say, then our baby came out, we tried and stimulated the baby. The baby's 1 minute APGAR was a 7. The 5 minute APGAR is a 9. Where does baby go?
Skin to skin with mom.
Skin to skin with mom. Why do I want to put baby skin to skin with mom?
It helps their thermal regulation.
Yeah, it helps thermal regulation. All right, so it's going to help the baby's body temperature. It's going to help prevent cold stress. It's going to help with bonding, breastfeeding, cardiopulmonary stability, all of this stuff. All of these are benefits of skin to skin. So now we'll go back and we'll talk about Sally and Molly. Sally is a G1, 38 weeks and 2 days in active labor. She's expecting a baby girl. She is named Molly. You observe abnormalities in the fetal heart tracing that may indicate fetal distress. What type of abnormalities would you anticipate seeing if the baby was in distress?
Late decelerations.
Good, late decelerations. What else might we see?
Minimal variability or absent.
Minimal or absent variability. Absence worse, right? Okay. What about like a prolonged deceleration? The heart rate is 80. And it's been 80 for the last 6 minutes. That's probably bad.
Not good. Really
That's
bad.
probably bad. Okay. What would I do? So depending on what we're looking at, so we said late decelerations first. What intervention would we implement?
Reposition mom.
Position mom. What else?
fluid bolus,
Okay, good.
or put the mom in hands and knees.
Okay,
Can you give oxygen as well?
okay.
Probably 38 weeks. If she's already active in labor, what am I thinking? The medications to stop contractions.
Okay,
I
so,
forgot what those are called.
okay, tocolytics.
That
All right, so let's slow the contractions down. Do you remember what medicine we usually use for that in this situation?
Turbia.
Yeah,
Terbutaline.
yep, yep,
Yeah.
good. You know it well enough that you would have recognized it, Katie, even if you can't pronounce it off the top of your head. If you saw it, you'd be like, yes, that's the one. And you're right, terbutaline is going to slow this down. Why would doing a tocolytic be a good idea for this patient?
Because if the baby's having latent decelerations after every contraction she's having, if she's having a whole lot of them, the baby is consistently in distress.
Okay,
So we need to slow
what's
them down and give them both a break in between.
good? Right? Because remember that every time she's contracting, we have less blood flow going through the placenta. Right? So the tocolytic is going to give that break, like you said. All right, so terbutaline. What's the side effect of terbutaline?
it affects the vitals per mainly the heart rate.
And what
So
happens to
you
the heart rate?
I'm gonna say goes up.
Yep, tachycardia.
Okay.
All right, so we could consider terbutaline. So we changed positions, we gave IV fluid, we gave oxygen, we gave terbutaline. And here's what happens next. It didn't help. The fetal heart tracing now shows a prolonged bradycardia. The provider suspects fetal asphyxia and requests to prepare for immediate delivery. How are we delivering baby Molly?
Cesarean.
Yeah, we're gonna have to go back to the OR. So baby comes out. What action will be performed immediately after birth to stimulate respiratory effort?
Suctioning.
Suction and vigorous rubbing.
Okay, so we're gonna try and stimulate the baby and maybe suction, probably suction. Molly is vigorously dried and stimulated. The 1 minute APGAR is assessed. The infant is blue, limp, does not respond to stimulation, is gasping, and has a heart rate of 90 beats per minute. So we already talked about why drying is important on that other slide. What's the 1 minute APGAR score?
5.
It would be 2.
2.
So let's go to our little tool for a second. So we're blue, limp, not responding to stimulation, gasping, and a heart rate of 90. So how many points for appearance?
Oh, 0.
0.
Okay, how many points for pulse?
1.
Okay. How many points for grimace?
That's the 1, right? Because she's got a feeble cry.
Well, it says
Or what did it say?
no response to stimulation.
Oh. Never mind.
And I think she's gasping. No. Let's find it. Does not respond to stimulation, is gasping, and has a heart rate of 90. So right now we gave her a point for pulse, probably a 0 on grimace.
With all the pillows.
Activity.
So the other one would be respirations because it's just weak and gaspy.
Okay. So no activity because we're limp and floppy. And then so 1 minute APGAR is a 2. All right. What intervention should we do next?
Give Molly some oxygen.
Maybe. All right, guys, most everything that you can assess, like when we're doing our APGAR and if we're below 7, most things can be fixed with oxygen. If we can get that baby oxygenating, everything else gets better. The heart rate comes up, the muscle tone improves, all of that. And so if we gave Molly oxygen, how would we give it to her?
Sorry.
A little baby face mask.
A little baby face mask. Okay, so we use positive pressure ventilation. All right, so little baby face mask, and we put it on there, and then we give breaths, because if the baby is gasping, it doesn't really count towards anything that's going to be beneficial for breathing. So we can do positive pressure ventilation with a bag and mask, and the baby is getting so much better. And at 5 minutes of life, she's crying. She's centrally pink with blue extremities, has a heart rate of 120, and has active movement with responsive stimulation. So let's go back to this. She's centrally pink with blue extremities. First of all, what is that called?
Acrocyanosis.
Acrocyanosis. Is that normal?
Yes.
It is normal. Is she going to lose a point for it on her APGAR score, though?
Yes.
Yes.
Yeah, she will. So she gets 1 point for appearance because her extremities are blue, but her centrally she's pink. What about pulse? How many points?
2.
2. So now we had 1 point for appearance. We'll give her 2 points for pulse. What about grimace?
She would get 2.
Okay. What about activity?
2.
And then what about respirations?
2.
So what's her 5-minute APGAR?
9.
9.
9. Okay, so what should happen to Molly now?
Go to mom.
Yep.
Skin to skin.
Let's go skin to skin with mom. Do you see her? She's pink. She's crying. She has good muscle tone. She looks great. So let's get her skin to skin. So she's placed skin to skin for bonding and begins to show feeding cues. What feeding cues might she be exhibiting?
Rooting.
Okay, good. What else?
Sucking on hands and fingers.
Mm-hmm.
Mouthing.
Good.
She might even crawl up to her mom's breast.
She might, yeah. Awesome. All right, how soon can Molly breastfeed?
Immediately after birth.
Yeah, she could breastfeed now. Good job. All right, so, and then we already talked about this stuff. So, so after baby has breastfed and been skin to skin with mom, and we're doing our assessment, one of the things we're going to do is the baby meds. And so we call them eyes and thighs. What are we thinking about for this?
Prophylactic antibiotics and vitamin K.
Good. And what is the purpose of the antibiotics?
To put it on the eyes to make sure that they're not infected with anything, whether mom knew or didn't know, with gonorrhea and chlamydia, or just anything in general.
Okay.
But mainly those two.
So ophthalmia neonatorum is the terminology of what we're trying to prevent. And you're exactly right. It's a conjunctivitis that happens to babies primarily if they're exposed to chlamydia or gonorrhea. Okay, so we give it to all babies. We don't know. Even if mom was negative at the beginning of pregnancy, I don't know what's been happening since that day. And so it's easy to protect babies' eyes. So we just do it for all the babies. What about the vitamin K?
It
Helps with clotting.
All right, so it helps for blood clotting and for hemostasis, because babies, when they're born, we have kind of a couple things happening. We have an immature liver, and then we have a sterile gut. And the gut is where they produce the vitamin K. And so these two things together can cause the baby to be at risk for vitamin K deficiency bleeding. And so if we give vitamin K, it's going to stimulate the production of the red blood cells to help prevent complications from hemorrhage. Usually the type of hemorrhaging we see is like brain bleeding. And so vitamin K is going to be the fix for that. Okay. All right.
God, I'm sorry. My whole something cut out, and the last thing I heard was vitamin K is going to be the fix for that. Can you tell me what it's the fix for? I apologize.
No, it could be my signal. Did it cut out for everybody else too?
No, I was
I heard
talking.
you.
Can anybody hear me? I can't hear anything. Everything's black. Can anybody hear me?
I can
So
hear you.
I can hear you.
I
You
can
could?
hear you. Yeah. So for vitamin K, well, somebody else tell Katie what vitamin K is for. I already know what it's for.
Vitamin K helps with blood clotting, especially with hemorrhaging for brain bleeds.
Okay, it stimulates the production of red blood cells.
Okay, thank you.
You're welcome. All right, so thermal regulation, we kind of talked about this already, right? With keeping our babies warm. We need to try to minimize cold stress. If babies get cold, then they start using their own brown fat because they can't shiver for warmth, and it puts them into a metabolic acidosis. It causes hypoglycemia. And so that's why skin to skin is important. That's why drying and stimulating your baby at delivery is important, to try to minimize the evaporative heat loss. And so next to respirations and circulation, thermal regulation is the most critical thing for babies. All right. So let's keep our babies warm. Next topic is when we're thinking, now we're going to kind of start thinking about what we're assessing for our baby. So we got our baby, we did our eyes and thighs, and now we're doing we're assessing and thinking about our different organ systems. Okay. So when we think about gastrointestinal, we are, again, considering vitamin K because the newborn gut is sterile and it's not synthesizing vitamin K yet. We already talked about feeding cues when we talked about baby Molly. What kind of stools will we see for our baby? What do you think?
You see meconium,
Mm-hmm.
which is that dark green, black in color, tarry, sticky, thick.
Perfect. And then what happens after that?
There's a transitional period between the meconium and then the 4th day.
And then what does it look like after transitional? If she's breastfeeding.
If she's breastfeeding, it will be yellow and seedy.
Yep. Okay. So meconium is that dark, thick, sticky. Transitional is kind of loose, brownish, greenish. And then we get to yellow seedy, usually by day 4. Because the milk comes in usually around day 3. And so with our breastfed baby, they're getting the colostrum, and then the milk comes in and the stool is transitioning. And so then once the milk comes in, we get that yellow seedy, and it's like a mustard color. Signs of respiratory distress. Katie already told them to us. Katie, can you hear us still?
Yeah, quite a bit of the gastro assessment was cutting out for me, but I think it's me. I don't know what's going on, but I'm here.
Okay.
I hear you said I already said the signs of respiratory distress.
Yep, you sure did.
Nasal, grunting, the intercostal retractions.
Yep.
And the seesaw breathing.
Yep. The one we didn't talk about that we need to also consider is going to be tachypnea. What's tachypnea?
Fast breathing.
Okay. And how fast is fast? More than how many breaths?
60.
More than 60. Okay. And so tachypnea, or babies breathing more than 60 breaths per minute, can be something that we see for a few reasons. It is a sign of respiratory distress. Okay. Oftentimes this can be when we have an inadequate fluid clearance. So what does that mean? Inadequate fluid clearance.
they didn't get squeezed enough going down the birth canal.
Yeah. So remember, guys, that amniotic fluid has been hanging out in the alveoli through pregnancy. And it was actually important to help expand those alveoli and help the lungs mature properly. But in labor, the fluid's supposed to get out. And then as the baby comes through the birth canal, they get that nice squeeze on the chest that helps to force that fluid out, so that when the baby delivers and they take that big breath, gas exchange can happen. If we don't have the fluid that is cleared out adequately, then maybe we have signs of respiratory distress because the baby's trying to work that fluid out. So if the baby, what would be a time when our baby wouldn't get a good chest squeeze?
C-sections.
C-sections. Okay, so babies, a lot of times babies, C-section babies have increased risk of inadequate fluid clearance, and so they can have signs of respiratory distress and tachypnea. Okay, good. What else could cause tachypnea, do you think, besides inadequate fluid clearance from C-section?
What's the one, the really fast burst? Would that cause it?
It could. Yep. What's that? What's Katie thinking of? Anybody know?
Is it precipitous?
Yeah, good. Precipitous birth. So babies that come down and out really fast might have an inadequate fluid clearance, and they can have tachypnea and signs of respiratory distress. What about if the baby passes meconium in utero and we have meconium stained fluid?
They're at risk for aspiration of it. So meconium aspiration syndrome.
Good. Meconium aspiration syndrome. If the baby aspirates meconium, do you think we'd see signs of respiratory distress and tachypnea?
Yes.
Yeah, right. Because of that stuff, we just talked about how on the GI slide, we talked about how meconium is sticky and gooey. If we mix that with amniotic fluid and we put it in the lungs, that's going to interfere with gas exchange. Okay, good. There's another thing that is called transient tachypnea of the newborn. And with transient tachypnea of the newborn, these babies can develop really rapid breathing, usually more than 100 breaths per minute. And this is something that is more prevalent, again, with inadequate fluid clearance. So our C-section babies, we can see this with for sure. Okay. Trying to think if there's anything else to say about respiratory distress. I think that's pretty good. All right, so bilirubin. What are some situations that could cause a baby's bilirubin to be high?
They're not voiding.
Say that again.
They're not voiding as much as they should.
Okay.
You said what would cause high bilirubin? Is that what you asked?
Mm-hmm.
Like birth injury, like bruising to the baby's head, or like the shoulder thing after they come out.
Okay. Shoulder dystocia or bruising. What about cephalomhematomas? Right? Anything that causes there to be any sort of bleeding in the tissues for the baby could increase the risk of bilirubin, because that every time the baby's body has to break down red blood cells, it releases bilirubin. Okay. Hemolytic disease. So if we had an ABO incompatibility and mom's antibodies are on baby's red blood cells and breaking those apart, that could cause it. If we had a mom who was Rh negative and her baby was positive and she didn't get RhoGAM and the next baby was positive, that would be what we call erythroblastosis fetalis, but we have a huge amount of red blood cell breakdown, so that could cause it. Okay. We also have what we call a breastfeeding jaundice, and that's just because that where if the baby's not latching well and isn't feeding well, then they're not excreting their bilirubin because they're not voiding and stooling as much, like you guys said. Okay, so all these things are things that we think about that could increase the risk of jaundice. So if my baby's bilirubin level is elevated, so what they do is at 24 hours, they will test a transcutaneous bilirubin level, and it's just a little machine that they tap onto the baby's skin, and it tells you with pretty close accuracy what the baby's bilirubin level is. And if it's elevated, then we draw blood work and we make sure. But if the baby's bilirubin is elevated, how would we treat?
Phototherapy.
Light.
Okay, good. Phototherapy. Why? What is that going to do for my baby?
It's gonna break down the bilirubin.
Good. Okay. So bilirubin, we have this term that's unconjugated and conjugated. So I think about unconjugated bilirubin like it's a big chunk. And phototherapy helps the body conjugate the bilirubin or break it down, the bilirubin that's circulating in the baby's body, and so that then the baby can easily excrete it. So we're going to feed our baby, get them peeing and pooping, use the phototherapy to conjugate the bilirubin and help them excrete it. Okay, because if we don't, what's the risk if the baby's bilirubin level is too high? Anybody know?
I don't know how to say it. It's kernicterus.
Yeah, kernicterus. And with kernicterus, because the thing is that with the bilirubin levels being really high, it can cause encephalopathy and kernicterus. So we can have babies that have seizures, that have cerebral palsy, and actually can even die. So that's why. How do we do phototherapy, do you think?
We get a little special crib. They get their own little special goggles. And I know at the hospital I did my clinicals at, they had it where there's a light above and then there's a light below in the crib as well. And the little baby just lays in there bare naked, getting all the light they can safely, of course.
Okay, good. So we got to protect the eyes. We want as much skin exposed as possible. And so for your baby, what you were talking about, they used a Billy light and a Billy blanket. So the baby had it come in from both sides. And so they can either be completely naked or they can be just a diaper, but we want as much skin exposed as possible. And then the light will help conjugate that bilirubin and break it down so the baby can pee and poop it out. All right.
It was kind of funny though, because we were talking to our instructors and they said what they used to do is just literally just put the baby by the window.
Absolutely. They did. That's true.
When I had my son, he had bruising on his head, like from when he came out, and his bilirubin was high. And they told me, just like when I would feed him, they were like, if you can sit by an open window, or like I had him in July, so I would just take him outside, like in his diaper, and sit on the porch for 15 minutes or whatever a day. And his went back down within a couple weeks.
So that's good. Yeah.
You'd think that also help mom getting that vitamin D, kind of that sunshine to help them both.
Yeah. And moms that are having baby blues, that's one of the things I encourage them to do is get outside, take a walk, breathe some fresh air, sit in the sunshine. So yeah, beneficial for a lot of reasons. All right, so skeletal and peripheral nervous system. So when we're thinking about, I want to make sure you guys kind of know the difference between brachial plexus injuries and clavicle fractures. All right. So there's a lot of different injuries that can happen, right? But these are the two that could seem similar between brachial plexus and clavicle. So what's a brachial plexus injury?
It affects the upper plexus nerve.
Okay. Which is where?
I want to say it's up towards the clavicle and the shoulder.
Okay, so the plexus, the nerve plexus, kind of lives in this area. And so if we have a baby that has a shoulder dystocia, and they're really pulling on that head to try to get the shoulder to come underneath the pubic bone, they can stretch or even tear the brachial plexus. All right. If we have a damage to the brachial plexus, what might I see with the baby?
A limp arm.
Completely limp. Okay. So we can have a paralysis on that side. And it takes a long time, because think about nerves take a long time to heal and regenerate. And so it can take months for this to resolve. All right. Now, also your shoulder dystocia patient could also have a clavicle fracture, right? Your baby, because of suprapubic pressure. And so what might I see if the clavicle's fractured? What do you think?
The Moro, there will be absent of the Moro reflex.
Well, so on the what's the Moro reflex?
Isn't it when, I don't know if it's this, but like when you hold them, they'd probably kind of slump in.
So Moro reflex. There's a few ways you can elicit it. One of them, you can hold the baby and then just kind of drop your hands a little bit. And it makes them, I feel bad because it makes them feel like they're going to fall. But they respond by going, don't let me fall. We call it the startle reflex. You can also elicit it by if you can check their palmar grasp when you're checking your reflexes, and when they hold onto your hands, you can just lift the shoulders a tiny bit up and then let go. And I don't mean like let the baby fall, but just a tiny little, and the same thing. So the more, or you can bump the crib. If they're sleeping, you bump the crib. Anything that startles them or makes them feel like unstable for a second will elicit this reflex. And so what happens with this is that both the arms come up, and with the clavicle fracture, the arm should move some. They shouldn't have paralysis like the brachial plexus injury does, but they're going to not move it as much. This is painful, and they don't have the same kind of range of motion. And so you'll have an unequal Moro reflex with the clavicle fracture. Plus, you might be able to palpate crepitus at the site. Okay, so if you have a shoulder dystocia, I'm worried about both of these things. But if the arm is limp and paralyzed, I'm thinking brachial plexus. If I have an unequal Moro response, I'm thinking clavicle fracture. Makes sense? So, and then when we were talking about how the A before a word is the absence of, when we were talking about atony, and I said asymmetrical, like asymmetric gluteal folds, and that's what we would see like with a hip dysplasia. As if the gluteal folds weren't even. All right, moving on to baby head. So a few things happen with the baby's head as the baby is delivering. The baby has suture lines. The bones are not fused. So you can especially see it really well on this pumpkin over here. You can see those suture lines. And if I can see the suture lines and the fontanelle this much, what do you think's going on with that baby?
They're dehydrated.
I think the baby's dehydrated, right? Because the fontanelle is depressed and sunken in, and I can see the suture lines. So maybe that baby's dehydrated, okay? But so these bones of the head are not fused so that they can shift and move to allow the baby's head to mold to fit the birth canal. And so that's what molding is. So if you look at the top baby, you see how we have that elongated look of the head because the bones have moved to fit, and then that'll resolve, and then the baby's head will go back to being round. And so the other things that we can see, One is called caput, and the other one's called cephalohematoma. With caput, we have that molding, so we have the elongated look, and then we have some edema on the presenting part of the head. And so it is superficial. It's just caused by pressure coming through the birth canal. So with this, the head's elongated, we have swelling of the soft tissue. It crosses the suture line. And so when we're talking about suture line, we're thinking about that pumpkin and where we can see those bone lines. Those are suture lines. This is superficial, so it crosses those suture lines and it's just elongated and it has swelling. It goes away. With our cephalohematoma is a deeper problem. So what is cephalohematoma?
It's when there's a big old collection of blood
Where?
in the head.
Yeah, cephalo is head, hematoma is collection of blood, it's in the head. This is a deeper problem. And so you can see in this picture with this baby that you can see where the hematoma or the blood pocket is, and it does not cross the suture line. Okay. This is also going to be a baby that has an increased risk of hyperbilirubinemia because the body is going to have to break all that blood down. Newborn reflexes. So we talked already about the startle or the moral reflex. Okay. What is the purpose of assessing the reflexes?
Make sure the nerves are intact.
Okay.
No injuries.
Right. It gives us an idea of the neurologic function, right? If we have a neurologic impairment, we might notice diminished certain reflexes, especially if the baby has been hypoxic. So like if they have a weak suck, or that's the one we see the most for neurologic. But these other ones all are giving us an idea of the neurologic function of the baby. Okay, so
Okay, hang on 1 second. My thing cut out again. I came back and it sounded like you said something about a sock. What'd you say?
suck.
Okay.
If
You said that's the most common one.
A weak suck is one of the more common things that we'll see with a neurologic impairment, or if the baby's been hypoxic during labor. Okay, but any of the newborn reflexes assess the neurologic function of the baby. So we talked about startle reflex already, things like Babinski. Remember that one where you stroke for Babinski, if I stroke the foot, what's supposed to happen?
They're supposed to draw it back.
The
They
toes
spread out, right?
splay out. With this one, the toe, you strike the foot and the toes splay out for Babinski. With palmar grasp and plantar grasp, if you put pressure either in the foot or the hand, then the fingers or the toes curl around. There's rooting if we stroke, they turn. And the root reflex really is something we can elicit to help with breastfeeding. If I'm trying to get a baby latched, then I'll stroke the cheeks or stroke the lips to get them to open their mouth. So those are our reflexes. All right, skin. So when we think about integumentary for our baby, there's so many different things that we're looking at and we're noticing. Most of them are normal. Okay, things like jaundice and well, jaundice is a big one that I would be concerned about. I'm trying to think what other ones I'd be concerned about. Central cyanosis, I'd be concerned about, things like that. But these ones on the slide, these are things that are normal findings. Okay, so vernix, what's vernix?
The protective covering, it's kind of like cheesy, like.
It's kind of cheesy. And so we can see it here. And this, I was gonna say baby Molly, but I had used the same picture for baby Molly. So you see the white cheesy stuff here? That's vernix. All right. And so babies have this in utero, and as they get closer to term, it starts to go away. So your babies, the earlier they're born, usually the more vernix you see. You can also see little bits of vernix in the amniotic fluid, and that'd be normal. And it's just kind of white and cheesy. Acrocyanosis. This baby here is a good example of acrocyanosis. You can see how he's pink in the middle, but look at his hands and feet. Okay, they had that bluish look. So acrocyanosis is a normal finding. Milia, what do you think milia is?
We always called them milk spots.
You
Little-
did?
Yeah. I didn't know
Aren't
that's
they
what
like
they were called.
clogged sweat glands?
Yeah. And so this one is that. I wonder if I can zoom it in. I remember my youngest one had this, and they almost look like tiny little pimples. And you kind of want to get them, but you need to teach parents to leave them alone. They'll go away on their own. Okay, so that's milia. Nevus simplex. This is a pretty exaggerated example, but this is what they also call a stork bite, and it's like a pink spot at the nape of the neck. And so this is really common, especially in Caucasian babies. And then Mongolian spots, we also call it hyperpigmentation in the newborn. And this is more common than for Mediterranean descent, Latin Americans, and those. And it looks like bruising. So if I zoom this one in, see how it's dark and discolored. This will fade, but it doesn't usually go away completely. And so this one is important to document so that it's known that the baby was born that way, so that there's not ever any questions about bruising. Erythema is newborn rash. It's just, I don't know if I have a picture. Yeah, here we go. Okay. And so that resolves on its own. It can take some weeks though to go away. And then lanugo. And lanugo is the little teeny tiny hairs that babies can be born with. Sometimes they have hair like on the little backs of their ears, on their shoulders, all over. And that goes away. All right, reproductive. So when we think about reproductive, there's a lot more to think about for our boys in this than for our girls. All right, so for our boys, we want to assess to see if the testicles have descended. We're looking for where the meatus is. Okay, when I'm looking for the meatus, if it's not at the tip of the penis, then what is it called?
Is it the hypo?
Yeah, well, it depends, right? What's hypo? Where's the meatus with hypo? Spadius.
It's under, right?
It's on the underside of the penis, on the glands. And then epispadius is if the meatus is towards the top. If your baby has a hypospadias or an epispadias, then they're not going to do a circumcision right now because they can use the foreskin to repair this. So in addition to looking at where the meatus is, we're also looking at the testicles. So not only we want to know if the testicles have descended, we're looking for color. We're looking for if it looks full and taut. We can do a transillumination where we just put a light underneath. And if the testicles glow, that gives us an idea of a hydrocele, which means there's fluid accumulation in there. Okay, so these are all things that we're assessing with our little boys. For our little girls, they might have breast buds. They might have some bloody mucousy discharge from their vagina. And their labia might be edematous. And these are all just related to mom's hormones.
So for the little boys, would we just like document if we saw any of those things and then someone above our pay grade fixes them? Or do they go on their own?
We would notify.
Okay.
Yeah. But, if your baby, if parents are wanting a circumcision and you're assessing the baby and you see the meatus isn't at where it's supposed to be, then that needs to be notified too right away, because a doctor will have to assess and determine if they need to delay the circumcision because of the hypospadias or the epispadias. And then if you see if you see bluish discoloration, that's a torsion, and we definitely need to notify right away because we're not getting good blood flow to the testicle. And then hydroseal with the fluid accumulation. So these are all things we would notify the provider for.
Okay.
There's not a lot we can do to fix this stuff. This stuff we're assessing, but that's a good question.
So for either one of them, whether it's below or above, circumcision is contraindicated for both, or is there one for more?
For
Okay.
either one, it's
Okay.
contraindicated because they can fix that and move the meatus to the tip of the penis, but they need the extra tissue to do it.
Thank you.
All right. Discharge planning and teaching. What kind of things do you think is important for moms and dads to know about for taking care of their baby when they go home?
How many wet diapers and how to monitor like the stools?
Okay. So how many wet diapers should a baby have?
6 to 8.
6 to 8 wet diapers a day. How many stools do you think?
When you say a day, do you mean in a 24-hour period or like a waking period for like a normal person?
In 24 hours.
Okay.
Yep. How many stools, do you think a breastfed baby has? Once the milk comes
Isn't
in,
it usually pretty frequent?
yeah, they usually have at least 3 substantial stools per day when they're breastfed. Yep. What else do we think that we want to teach parents about?
Like peri care, for like if you had a little boy and he was circumcised, like how to keep that clean, same way with the belly button. With the
Good.
cord.
Yep, good.
So you want to keep that dry. Don't mess with it. Don't pull on it.
Okay.
If they have like an umbilical hernia,
Mhm.
like if it's poking out at all, signs to look for that, or like if the baby seems like it's not comfortable to put the diaper over it and things like that.
Good.
How
Safety
often
things.
fed
How often what?
the baby should be fed.
Okay, how often the baby should be fed. So the feeding cues, like we talked about when we did baby Molly. Okay, what safety things? Who said safety?
They need to be sleeping on their back, usually alone. I know that's hard for some parents. And like no items, like no toys or things that they could, I don't know, just plop in their mouth. And when they're sleeping in a car seat, making sure they don't like slump over and cut off their own respiratory or respiration.
Absolutely. Yep, that's so true. Yeah, and so actually babies that are under a certain weight, they do a car seat challenge before they go home to make sure, because that they can so easily cut off their own airway just slumping in their car seat. Yep, good. Awesome job. All right, so these are all things that we're going to be teaching parents about on discharge.
And I remember my nurse telling me that as far as keeping my baby warm, I just saw the first thing on that slide. I remember her telling me that a baby will tell you if they're too cold, but they won't tell you if they're too hot. So just be careful when you're swaddling them. You don't want to use like thick fleece blankets to do that. They'll tell you if they're too cold.
Right. True. And so it's kind of a hard balance, because we when babies are first born, we dry them off and we do double swaddle in the beginning and stuff like that, because thermal regulation is so important, and skin to skin and all those things. But once a baby starts, outside of that transition period, they start they have their own temperature stability and maintaining their own temp. And like you said, they will tell you if they're cold. But we also don't want cold stress, because remember, if they they also don't shiver. So if you see your baby kind of bunching up and trying, if we went back to that thermoregulation slide, there's a little bit about positioning, attempting to generate heat by increasing muscle activity, position of flexion, non-shivering thermogenesis. So if they start really hunching themselves up and stuff, they are also trying to stay warm. But you're right, if they are too warm, there's not a way that they really tell you that. So that's a good point. Okay. All right, so drug exposed infants. So when we think about babies that are exposed to drugs, we had talked about substance abuse as it related to the pregnancy, but we now are looking at how that affects the baby. If the mom is using substances like opioids, marijuana, if she is an occasional drink's okay, but if she's an alcoholic or she's using meth and all those things, that crosses the placenta. It crosses in the breast milk. Okay. So these babies, not only do we not want moms to be using these substances during pregnancy, but we don't really want her to be using them if she's breastfeeding either. So methadone is a good choice as an alternate to the opioids, and she can breastfeed with that. Okay. And I want to kind of stress, and I don't even know if it's on the slide. Let me see. It's not, but so I just recently moved from Colorado, and in Colorado, marijuana is legal. And in other states it is now too, but Colorado is kind of the, one of the first ones. And so pregnant women would think that since marijuana is legal, they can use it too. And it's actually not legal in pregnancy. And so it also is something that we consider a substance that, so a patient last night had a history of THC use through her vape, and we still had to tox screen the baby at delivery because of that. So don't discount marijuana, because that one counts too. Neonatal abstinence syndrome. So how long the baby's been exposed to drugs is going to somewhat affect the way the baby withdraws from it. What are some things that we might see if our baby's withdrawing?
They'll be irritable. They might have seizures, a high-pitched cry, tremors, yawning, excessive sneezing.
Okay, lots of yawning and sneezing with these babies. And hypertonia, so tremors and increased muscle tone. High-pitched cry is a big one. Okay, they might be diaphoretic. Okay, how do we take care of them?
Make sure they're swaddled. Really watch their temperature. Frequent
Feedings.
Okay, good. Yeah, so we just really want to decrease stimulation for these babies too. So we're going to keep them swaddled and keep them in a quiet environment. And oftentimes they just really need to be held. There's some hospitals that they have people that they hire that's the job. So hold the baby. Okay, the withdrawing babies. And so in my class, I also posted in the discussion board about the Eat, Sleep, Console model. So there's a lot of things that we're looking at in trying to be able to evaluate and assess how the baby is withdrawing, and as non-pharmacologically as possible. Oftentimes, so these babies need medications also as they withdraw. It takes a while. All right, preterm birth. If we have a baby that's preterm, what's their gestational age is less than what?
37.
Less than 37 weeks. And so what are things that we're thinking about for our preterm babies? What are their increased risks?
Respiratory issues.
Respiratory issues. Okay. So what do you mean by that?
So the surfactant, if they were born before 35, is not fully matured. So hopefully they were in mom enough to at least maybe get a dose of steroids, and then 24 hours later another dose. But of course, if baby's having issues, they're going to be born before that, so they're going to be having deficiencies with that, meaning their alveoli are not inflating like they should.
Right. That's true. What if I told my students about a patient that had a placenta previa and she hemorrhaged horribly, and we had to do a C-section, and she was 30 weeks. And so that baby definitely has a surfactant deficiency. If we didn't get steroids on board and we didn't get everything done before she hemorrhaged, then if we have an unequal inflation of the alveoli and we have atelectasis, then we're not getting good gas exchange. Can I give this baby surfactant after they're born?
Yeah, in an inhaled
Yes.
form.
Okay,
As
we can, and usually they actually have to put an endotracheal tube in, like they have to intubate and put it down an ET tube. Okay, so I don't know if if you can give it as an inhaled form. I've only seen it with the ET tube, but we can give it, and so that's important because that's going to help for all the reasons that you guys just said. Okay, so that's one of the things that we think about is respiratory. What else is this baby, preterm baby, at risk for?
Immaturity of his organs, his or her organs.
True. Yep.
infection.
Yep. Higher level of infection.
Higher risk of a potential of a disability.
Yeah, depending on how early, definitely. Okay, the younger they are gestationally, the more that that can be affected. Okay. So also higher risk of hyperbilirubinemia, higher risk of hypoglycemia. If this baby, our preterm infants have the higher risk of infection and sepsis, what kind of things might I see if my baby had an infection?
Fever.
Actually not. Usually babies, it's kind of weird, but usually babies with an infection, they have temperature and and they get cold.
Okay.
Yeah. Okay.
Would they still be tachycardic?
They could be. They don't usually eat well. So if they have poor feeding and they have temperature instability, if there's tachypnea is one, signs of respiratory distress, all of these things we might want to do blood cultures and assess. Okay.
So would you say a feeding in general is because we have our vitals, but like you said, they're different when it comes to fevers or not getting fevers. So would you say feeding is your main indicator? If they're not eating like they were or doing that way, something's going on, no matter what kind of baseline in general?
Well, it's a sign. I think that oftentimes if something's going on with our baby, we're seeing respiratory symptoms a lot of the time, but it can be poor feeding. It can be like decreased muscle tone. It can be some of those things, but temperature instability and
you're going to see
feeding,
it no matter what. For most of these stuff is you're going to see poor feeding, more say, not that poor feeding is causing this.
Right. No, I know what you're saying. And a lot of the time I do think that because even like with our baby that is is withdrawing, will have uncoordinated sucking and poor feeding. Our preterm babies in general have a hard time with feeding though, because that depending on how early they are, coordinating suck, breathe, and swallow is kind of hard. But if you, like you're saying, if you see a change in the feeding, that would definitely be an indication that, I wonder what's going on with this baby. He was eating fine and now he's not. That can be a sign of an infection too, if we have poor feeding. All right, so if mom's diabetic, how does that affect baby?
They can be big.
What's that?
They can be big.
They can be big. All right, so what's it when we think about a big baby? What's our term for that?
Macrosomia.
Macrosomia. And after they're born, we call them large for gestational age, or LGA. And so those are babies that are greater than the 90th percentile for their gestational age. There's like a chart. Okay. So our babies that are big, what are they at risk for?
Shoulder dystocia.
Yep. Birth injury, shoulder dystocia. And hypoglycemia. And if mom's diabetic, we have a situation where if she has poor glycemic control, her body has tons of glucose that's giving that baby. And babies' bodies make their own insulin. Okay, insulin is not crossing the placenta to the baby. And so baby's body makes a ton of insulin because that mom's body is giving that baby a ton of glucose. And if this happens over time, then these babies, the constant high level production of insulin decreases their surfactant. And so babies that are born to diabetic moms that have poor glycemic control can also have signs of respiratory distress. And so for both our preterm babies and our babies that are born to diabetic moms, they can develop what's called respiratory distress syndrome. And so for both of them, it's because of a surfactant deficiency. Okay, but our signs and symptoms are the same as what Katie said before, with the grunting and the nasal flaring and the retractions and the tachypnea. Okay, so if mom's diabetic, we're worried about hypoglycemia, we're worried about birth injuries, we're worried about respiratory distress. So these are all things that we're going to assess for. What should we do for this baby that's at an increased risk of hypoglycemia?
Check the blood sugars.
Check the blood sugars. What else?
You'll feed the baby.
Feed the baby. We want to feed this baby really frequently. Okay, every hour or two, we should be trying to get this baby eating. All right, because it's going to help minimize the hypoglycemia. And then we're watching the blood sugars. We're checking the blood sugar before every feeding.
Now with this, will the baby like balance itself out after a couple days? Like, will its body start making the correct amount of insulin?
Yeah, it balances out pretty quickly usually. Yep. Because the baby's body, even though it's making a lot of insulin at birth, because based on the glucose it's been receiving, its body is going to notice what glucose it has now, and it's going to adjust the same way ours does, but it just takes some time to make that transition. Okay, breastfeeding. So for breastfeeding, we are going to be thinking about first our hormones that help with breastfeeding. So what are the two things? What are the two hormones?
Prolactin and oxytocin.
Prolactin and oxytocin. Prolactin is going to help with the production of the milk. Oxytocin is going to help with the letdown of the milk. Okay, and so it makes a loop. So we fill the breast and we empty the breast, and we fill the breast and we empty the breast. Oxytocin though, it does other things in the mom's body as well. Do you remember what?
The contractions
It
or
helps. Yeah, it helps the
Sorry.
uterus to contract. Yeah, it's just agreeing with you. Okay, so it helps the uterus to contract. So when she breastfeeds her baby, oxytocin's released. It tells the milk to let down, but she might also have cramping, which is normal. But sometimes we need to educate for that because that they think maybe something's wrong, but it's normal. And if it's really uncomfortable, they can take Tylenol or ibuprofen. Okay. But that really helps with involution because it's helping the uterus to return back to its pre-pregnant state. So that's good. If our patient back when we were having this hemorrhaging patient back up here, one of the things we could do even is latch the baby, right? Because remember we massaged the fundus and we emptied the bladder and we talked about all the medicines we could get, but we could also put the baby to the breast and that would help the mom's body release its own oxytocin. All right. So for latch, what's important about latching? Do you think?
That the nipple is far enough in their mouth
Why?
because they need hard palate stimulation in order to latch correctly.
Well, so hi Lena, I had sent out, I'm sorry, I have a message in the chat about the fact that this was starting at 2. And it was starting at 2, and I had sent out a message to all of the instructors to notify students that we actually had to move to noon. So we started at noon. So I apologize that you didn't, I apologize that you weren't told, but we're finishing up and then there will also be a recording posted.
Okay, thank you so much for this.
Okay, I'm very sorry that that didn't get passed along to you.
No, it's okay.
Okay, sorry. So we're talking about latch, and Katie's talking about the hard palate, and that plays a role in this. And so what we're concerned about is that if we don't get a good latch that's deep, then it can cause tissue damage to the nipple. And so we actually want the nipple to be kind of a little bit past where the hard palate is so that when the baby's tongue is putting pressure on the tissue, it's not causing firm compression that can cause blisters and bleeding and cracking and stuff like that. And so we need to be assessing this latch from the very first feeding, because that if we don't have a proper latch, even from the very first feeding, we're going to get tissue trauma and it's going to be harder to set this mom up for success with breastfeeding. For the breastfeeding mom, what are some things that we need to teach her about? We talked about mastitis, and that was important on how we care for mastitis. What other things do you think she needs to know?
She needs to have the nutrition for herself as well.
She does. So she needs to make sure she's eating at least 500 extra calories. Well, not at least. We don't want her to overeat, but she needs to allow a few extra calories, like 500 for production of breast milk, and eat a really good diet. Good for her, good for baby. Okay. What else?
Not to rely on breastfeeding as like a form of birth control. And then also not to wash her breast with soap.
Right, good. Not to wash her breast with soap, because why?
Doesn't it dries out the nipples?
Yeah, it sure does. It can dry the nipples and cause them to crack. Okay, so not using it as a form of birth control. because oftentimes women don't have periods for a while they're breastfeeding, so they think that they're not ovulating. But at some point they're going to ovulate and they're not going to know. Okay. Let's also teach mom those things. We remember when we talked about the feeding cues? We're going to teach her that. Okay. What if she wants to formula feed? Or let's just say, what if she doesn't want to breastfeed? Formula is number 2. Okay. Formula is, well, formulated to mimic breast milk as closely as it can. And so it's going to give the baby the vitamins and the minerals that they need. We don't want, even formula fed bottle babies shouldn't be on a strict feeding schedule. Okay. So math, there are going to be 5 math questions. They're just like every other exam. Things like, and I'm going to say with every bit of honesty, I haven't looked at what's on the math this test, but things that we have seen historically on exam 3, and the math always changes, is heparin calculations, and milligrams to milliliters, converting grams to milligrams, weight. So if you have weight-based, then you're doing pounds to kilos, things like that. All right. Let me look and see what this has here. Calculate the dose. 1/2 times volume. Okay, so this is an example of how to calculate heparin. And I feel like this one is easier than the whole cross multiplying stuff. So let's just look at this heparin one real quick. Start with what you know. So this is whenever I look at a map, let me find one so that I can show you what we mean. Hold on one second. Heparin map. Okay, let's just do this and we're not going to do the bolus though. Hold on. So I'm going to put it in the chat. Okay. And so what we're looking at for this is the doctor orders for your patient to start an IV heparin drip. And so we're going to start with what we know. And so let me go back to the slide. And so I start by writing down what I know. And so it says we want 18 units per kilo per hour. So I'm going to write down the dose, 18 units per kilo per hour. And then don't worry about the loading dose, okay? And so now what's provided? So what we have on hand is 25,000 units in 500 mLs. And the patient weighs 172 pounds. Okay. So that's what I'm going to start out doing. I'm going to just write down what I know. All right. Now, what it wants to know is what the flow rate is going to be for the pump at milliliters per hour. So how am I going to solve this? Anybody?
You have to convert your pounds to kilos.
Okay, let's convert the pounds to kilos. So who knows how many kilos this is?
78.
Is it 78? What is it?
78.
$78.18. So it depends on, I encourage you not to do any rounding until the end. And so it's technically 78.1818. And so when I'm doing this on my calculator, I might just leave that number with what it came up with. Okay. But if we do it just 0.18 and we drop this, we're going to probably still be pretty close. But I really encourage you not to round until the end. Okay. So,
Professor McBride, I'm sorry to interrupt you. Can I ask a question? Did you just start or
no, I had sent out a message and said I had to change my time to noon. And I had sent it to the instructors yesterday, and I sent it out to my students by email, and I posted it in the announcements. So I do apologize for those of you that didn't get the information. I actually almost canceled completely because that I have been sick, but I did have to start early. So I will be posting the recording though. So I'm very sorry.
Okay, thank you.
Yeah, I'm sorry. So,
Professor,
yep.
sorry, do you mind sending it to our email address?
I don't mind. You can put your email address in the chat and yeah, because I was gonna say, I'll just post it in the chat, but I can't because I have to get out of this to upload it.
Okay, thank you.
On YouTube. But yeah, if you send me your email address, I'll do it. Okay. I'm really sorry for those of you that are just coming in and didn't know. I'm really sorry. Okay, we're working on heparin. Okay, so in the chat, what I have is I have an MD order for heparin, 18 units per kilo per hour. Administer, we're not going to do the loading dose. We have on hand is 25,000 units and 500 mLs, and the patient weighs 172 pounds. So the first thing we did was we converted the pounds to kilos. What is the next thing we should do?
Multiply by 18.
Why do you want to multiply by 18?
Is it 18? Because it was 18 units per kilogram per hour.
Yep, absolutely right. So we're gonna, so that she's looking at this first part here, what the order is. So we're gonna do 78.18. And like I said, guys, I encourage you not to round until the end. And so whatever I have on my calculator, I'm not going to write the whole thing out right here, but I'm probably going to just leave it at 78.18181818. And then I'm going to multiply by 18 because that's my dose. Now, truly for this, rounding early probably wouldn't matter. But when we're thinking about, especially like our pediatric dosing and things like that, rounding early can change the whole dose of a medication for a child. Okay. So we get, if I multiply it, what do you get? $78.818 times 18. Okay, 1407. All right, and I have 1407.2727. So 1407, now this is what our dose is. Okay, because we converted our pounds to kilos and we multiplied our kilos because our order was for 18 units per kilo. So now this is what we want. Now you can solve this with want over half times volume. So what I want is 1407, and I'll put 0.27. What I have is this, 25,000. And then we multiply it by the volume in our bag, which is 500. So if I say 1407.2727 divided by 25,000 times 500, what do you get? Was anybody working on this? All right.
28.1454.
There you go. And so the answer is, and then you can round wherever it wants you to round to the nearest hundredth. If we round to the nearest hundredth, what's the answer? If we round to the nearest hundredth, we have 28.145, and the nearest hundredth is that 4. So we're going to round that, the next number after it's a 5, so it would round up to 28.15. Okay. If we round to the nearest whole number, what's the answer?
28.
28.
Okay, so that is a way to solve those heparin questions. If you do the steps, if you first convert to kilos and then you solve the amount per kilo per unit, then you can just set it up that way. What I want over what I have times the volume in my bag, and that's how you can solve the heparin.
I have a question. So I definitely know I did this wrong on the last test because I converted my units to milliliters.
Okay.
So do we only do that for insulin? Because I watched a video and I think it confused me because I thought I saw a video that said that we had to convert our units to milliliters. So I think I may have confused myself.
With insulin, usually like for an insulin drip, it is usually like 100 units per 100 ml so that it's a 1-to-1 ratio. So you shouldn't have to do any converting.
Okay, so we will never convert our units to mLs for these heparin questions.
No.
Oh my goodness, face palm. Thank you.
You're welcome. Yeah, and I'm going to tell you guys, when I started my new job, I had to take a math test, and heparin was on it. And I'm going to say with every bit of honesty that if I wasn't teaching you guys how to solve heparin, I might have struggled with that. Okay. But you do have to do it in practice. I do a lot of math actually in relation to my diabetic patients, even in OB, because they want to know, you have to calculate how you determine their insulin dosing is based on their carb intake. And so there's all sorts of math equations that are happening all the time. So I have some students that say, well, pharmacy is going to figure this out for me when I'm a nurse. And actually, that's not the case. I do math every day at work. And so I want you guys to feel comfortable with these things. And you need to double check. I've caught med errors because the pharmacy said this is the dose. And I looked at it and go, that's not the dose. That's what it says it on the label, but that's not what you sent me up or whatever. Okay, so math is super important. All right, so that's how you can do heparin. There's other ways too, but I feel like that's the easiest. because that if you can make it a 1/2 times volume equation, I think that that's easier. So that's how you do that one. And then conversions, making sure that you do, sorry, I was looking to see what else was in the slides. Making sure that you do, with your conversions, that if it's like, it gives you the information in milligrams, but wants to know how many grams you're giving or whatever, that you notice that and you make those conversions, you round where you're supposed to round. In the PowerPoint itself, there is some practice. And then the answers are included with the rationales. And so you can practice it. I think I might have a Kahoot game for it. Let me look. Exam 1, exam 2. Nope. So if you're in my class, I posted recordings, but any of the Kahoot games that are about either postpartum complications or newborn would be worth looking at. So I can send recordings to you guys. Practice the math questions. Can you send it? So on what I just did, Lena, on the math was I just had for math how to calculate heparin, and that's what we were practicing. Okay. So this one, let's see. Do we know the weight? Nope. So that's why we used a different problem. So here's what I just was showing you guys how to calculate heparin specifically. Okay.